Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced by the Institute for the Advancement of Breastfeeding and Lactation Education and is co-sponsored by the Academy of Breastfeeding Medicine. Hi, Karen. How are you?
I'm great, Anne. How are you?
Good. So nice to see you. Yeah, so let's talk about some interesting stuff today.
Yeah, so I pulled a couple of things. The first one is from this last edition of Breastfeeding Medicine, which I just got. It was from December of 2020. And there was a case study titled Delayed Hemorrhage Following Laser Frenotomy Leading to Hypovolemic Shock by Dong-Hyun Kim, Alexander Dickey, and others. And in it, in the abstract, they wrote, ankyloglasia is a failure of the tongue to release from the oral floor with reported consequences that include breastfeeding difficulties and speech impediments. Frenotomy is a commonly performed procedure for the treatment of ankyloglasia. LASER, which is an acronym for light amplification by stimulation emulsion of radiation, is one of several mediums used to perform frenotomies. Although most frenotomies are uncomplicated, there remains a small possibility of complication, such as infection, pain, ductal injury, and hemorrhage, even in expert hands. Because frenotomies are most often performed in infants, postoperative hemorrhage is an important complication to look for. Even small amounts of blood may prove fatal due to low blood volume reserve. The authors report a case of delayed hemorrhage 7 days after an uncomplicated laser frenotomy in a 6-week-old infant displaying shock symptoms and required fluid resuscitation. And they go on just to, they talk a lot about this particular case and about the procedure and how it's done. And they make the point that there's been an exponential increase in the diagnosis of ankyloglasia in recent decades, with one reported increase of 834%. And so it's paramount to weigh the clinical benefits and the risks of frenotomy. And I was struck by this case because I know of 2 similar cases in my institution. There's actually a doctor writing up a case series right now. And when I was once at the AAP conference, was talking to another PICU doctor about a case where they had a baby with significant hemorrhage after this procedure in their PICU. And so I feel like there's probably underreporting of the complications. And because it is being done so much more frequently, I think it's something that people really need to be aware of, because they often recommend this as though there were no risks.
Yes, and so in this case, it's interesting to me that this hemorrhage started so long after a laser treatment, because I think of laser as really coagulating quite well. And so I'm curious about why they thought that happened. And was the baby low on vitamin K, or did the baby have any kind of, blood dyscrasia or some blood clotting disorder, I should say?
I don't think that they did in this case. In one of the cases at our institution, the infant did have an underlying, it turned out, mitochondrial disease, that the baby had some health problems. But I mean, that also goes to, this is being done in a patient population that can have undiscovered congenital or genetic anomalies. And I often, when I'm teaching the medical students, say, never trust a baby. You don't know that their plumbing is connected correctly, when they're acting funny. We have to consider all sorts of possibilities. And also, one of ours that was not the one I just mentioned, that was a normal baby, had bleeding 6 days after a scissor procedure.
Wow.
And so I think that it's a scary thought, because the blood volume of an infant is similar to a can of soda. and they just don't have a lot
Very
to
good. That's a really
spare.
good way to put it for people to understand. I also think that people do, I think people do really consider frenotomy to be a benign procedure. And in addition, I think there's scarring down that happens. We don't know about chronic pain. I mean, certainly we see babies who are so much better after frenotomy. I had a patient just last week who came up from Illinois, and they saw me in the breastfeeding medicine clinic for a number of breastfeeding issues. It was a home birth, and I don't know anyone, in that area that does, in that particular region of Illinois, that does home births. I don't know anyone in Illinois who does home births, but I know our midwives in our area who do home births, and our patients here who have home births typically are well taken care of, and they typically get their vitamin K. Well, I did a frenotomy on this patient, and I know they mentioned the home birth. I didn't even think about the vitamin K because it's generally not an issue for our home births where I am. But then after I clipped it, it wasn't even it was just an anterior clipping. It was a very thin, relatively avascular, little frenulum, and I didn't really go into the posterior compartment, maybe nicked it a tiny bit, but nothing that I would have expected to bleed more than, 30 seconds or something. But this bled for, oozed for about 5 minutes. And I thought that was unusual. And I said, did you give your baby vitamin K? And they said, no, we decided not to. And I really, really got upset. And they went home and gave the baby the vitamin K. But this baby was already a month old, 6 weeks, right? So then they're getting to that point of like, oh my God. So then I really, took a very good look at this baby, didn't see any evidence of petechia or purpura or anything like that. But I just said to them, you get into a car accident, your baby can die bleeding, I mean, what, and so, and their concern about the vitamin K was that it has a lot of ingredients that look scary, all the, additives for the oral vitamin K. So they, of course, refused the shot vitamin K. So you always have to make sure that you're asking about vitamin K as well, which I just was so guilty. Again, it's out of my, it's just unheard of for our patients around in this area to not get it. So yeah.
Well, and there isn't, I mean, maybe you have a different opinion, but my understanding is that oral vitamin K is suboptimal. Like I would much prefer for them to have the shot.
My understanding is that they have to have 2 doses. If they have 2 doses, and I haven't looked at the literature for a long time, so I really shouldn't. This is not at all,
this isn't something that we have to worry about every day, thankfully,
right,
because
exactly,
we don't live in a third world country. Oh, wait, people are making choices like they just don't appreciate what medicine can do for us.
Right, exactly. Yeah.
Okay, I'm gonna not rant. It's your turn. What case do you want to talk about?
So this is like another one of these, like, gosh, we should be aware of this. This was actually a case report it was entitled Unilateral Breast Inflation Caused by Breastfeeding After Polyacrylamide Hydrogel Injection. And so apparently this PAAG, this polyacrylamide hydrogel, is this like globish stuff that you can inject in the breast. You're shaking your head, Karen.
I mean, I heard about this and I was just very distressed to hear that.
Yes. Well, I talked to our friend, Dr. Mitchell, about it, and she was just like, yep, this is happening in lots of other places. But in this article, they state that this PAAG is widely used in Russia and in China as an injection material for cosmetic surgery in lieu of having any kind of an implant, right? Because it's cheaper, it's easier. And so this was a case report of a woman who was 36 and 4 years prior to that had injections of this material in her breasts. And then, so 4 years later after the injection, she gets pregnant. And then around a month after she gave birth, or somewhere within that first month, her breast became like, one breast became so super large and she couldn't get any milk out of it, that it just sort of like became like this really filled up taut balloon that they couldn't do anything with. And so she was referred to the surgeon's office. They weren't sure if initially she was given antibiotics thinking that she just had a breast infection in that breast. But her white count was normal. Her C-reactive protein was normal, maybe slightly elevated. So they did a CT of it, and it showed that the breast had this marked amount of fluid retention in the left breast, and it kind of like expanded between the chest wall and the breast tissue. So there was this big like expanding mass of material that was compressing the breast tissue. And so they felt that they really couldn't do much about it other than they tried to suppress lactation. And what they needed to do is just open up the breast and remove this gob of stuff. And they just got all this like yellowish, white, odorless material that was just like mud. And they said that because it like adheres to the chest wall and to the mammary tissue, it just kind of congeals and you can't really remove all of it. And so needless to say, she had to wean. But they're saying that, this is really unsafe for women in general, for their health. There have been some other complications used from this material, such as granuloma formation and breast deformities, and it can delay the detection of breast cancer. So yeah, this is something that we really want to be aware of, that if someone does present with unusual breast swelling and they're lactating in that, the first few weeks, and they are from another location, someplace that you may not know about their culturally, they may be new to this country or something. I've never heard of people really using it in this country, but on the other hand, we had that case of that non-doctor who's injecting stuff into people's butts for
somehow I missed that. I'm gonna let it go.
They were injecting it into the gluteus. And so there were all these women who got infections in their glutea, and their, glutei. Yes. And so injections, I think, do probably happen here, but just for us to be aware of it, because it is happening in various countries. So
I'm so blown away, like how people can get away with doing that to other humans, why people would think that was a good idea, why cosmetic things are so much more important than health. Like, I just can't.
Well, I think that they're a lot cheaper, and the people who are doing it are, it's difficult for the people who are consuming this care to know how to assess the quality. Here's someone who has this procedure offer, just like if someone's going to go get cosmetic surgery for whatever it is, how do you know they're going to do a good job? How do you assess it? Health literacy. I don't even know how to tell them how to figure it out, but talk to the primary care physician who's board certified, I guess. But yeah.
I guess well, that is a perfect segue into our next topic, which is choosing wisely. So beginning in 2012, the American Board of Internal Medicine Foundation started putting out these lists called Choosing Wisely. And in January 2021, the second iteration of the Choosing Wisely list for pediatric hospital medicine became available on their website. For those who are not familiar, this ABIM Foundation seeks to advance a national dialogue on avoiding unnecessary medical tests, treatments, and procedures. Its mission is to promote conversations between clinicians and patients by helping patients choose care that is supported by evidence, not duplicative of other tests or procedures already received, free from harm, and truly necessary. So this group has national organizations representing medical specialists ask their members to identify tests or procedures commonly used in their field whose necessity should be questioned and discussed. They had a call to action that resulted in specialty-specific lists of, quote, things providers and patients should question. The updated pediatric hospital medicine list is titled 5 Things Physicians and Patients Should Question, and 2 of the 5 new items relate to the care of newborns. So I wanted to touch on those. The first states, do not initiate phototherapy in term or late preterm well-appearing infants with neonatal hyperbilirubinemia if their bilirubin is below levels at which the AAP guidelines recommend treatment. The risk of poor neurologic outcomes, such as cerebral palsy due to kernicterus, is extremely low for term and late preterm newborns with modestly elevated bilirubin levels. Confirmed cases of kernicterus have average bilirubin levels near 40 milligrams per deciliter and are typically associated with hemolysis. While phototherapy for bilirubin values above published thresholds may be useful to prevent severe bilirubinemia and exchange transfusions, its use for bilirubin values below published thresholds is unnecessary and is associated with additional costs and unnecessary hospitalization. And I think that's really important because, we definitely see variations in practice. For years, the online Billy tool that so many physicians use to determine the need for phototherapy has said at the bottom, the AAP says you can start treatment at levels 2 to 3 below those, the line on the table. And sometimes that is done because families have limited transportation or other social factors. But I think some people have gotten the habit of doing it quite frequently, and it does cause separation. And, babies often aren't able to be skin to skin. Although where I trained, they did have these cool sunglasses the moms could wear while the baby was skin to skin on them and getting phototherapy on their back.
So, so of course I'm significantly older than you, and just a little history on this. So, back in the 1990s, so before the 1990s, we used to, in my residency, we had a lot of formula-fed babies, right? We didn't have that much breastfeeding, but if they were yellow, we would do Billy's right away. And we did ABOs, and every mother who was O positive, or O, I should say, we did the blood type on the baby and checked for Billy. So we were very, very vigilant. And then somewhere in the mid 1990s, there was this term coined called vigintiphobia, which is the fear of unbound bilirubin. And so we used to talk about like, oh, we're fear, this is just ridiculous. We should just stop worrying about all this hyperbilirubinemia. And so a lot of hospitals during that time stopped routine checking. And then no one was worried about it. And we were saying the same thing, like this bilirubin thing, this is ridiculous. We're not, we don't need to pay attention to this. But then as the breastfeeding, from my point of view, as the breastfeeding rates have increased, we started to see more hyperbilirubinemia and more concerns about kernicterus, more concerns about exchange transfusions, obviously not managing breastfeeding very well.
Well, and the other piece that I remember, because Bhutani spoke at the ABM conference a number of years ago, and I think that's where I learned that around that time, because of the sort of introduction of more managed care and the reduction in hospital stays before discharge for moms, but the pediatricians were still following up the babies at 2 weeks, there were babies that started to fall through the cracks and weren't seen in a timely way.
Right. There were a number of reasons. So that was at the time that we were seeing more breastfeeding rates, but then the care regarding those breastfeeding patients was not optimal, right? They were being seen at 2 weeks. They were leaving early. Breastfeeding wasn't well established, et cetera. So then we started seeing more complications, many more hospitalizations for coming back to the NICU with Billy's in their 20, at 20 on day 3 or day 4. And so then I remember when our hospital decided, okay, now we're going to reverse course. We're going to stop just using our clinical judgment, where we're going to test everyone at 24 hours. And so now I think the pendulum has swung again, where the Choosing Wisely campaign is like, would you stop worrying about this? But that's a little bit more of a gentle swoop of the pendulum, because they're not saying stop routine screening. But what they're doing is they're just saying stop the unnecessary treatment. Yeah.
Yeah, and I think that that's a nice balance, because it's nice to know the screening is important, but that doesn't mean that we always have to treat every baby. So the other one that was relevant to my patients, my newborns, is do not start IV antibiotic therapy on well-appearing newborn infants with isolated risk factors for sepsis, such as maternal chorioamnionitis, prolonged rupture of membranes, or untreated group B streptococcal colonization. Use clinical tools such as an evidence-based sepsis risk calculator to guide management. And they go on to say, unnecessary exposure of infants to antibiotics is associated with increased parental anxiety, length of stay, increased cost, gut microbiome dysbiosis, necrotizing enterocolitis, and possibly allergic and autoimmune diseases. Antibiotic therapy often leads to transfers to higher levels of care and thus decreased maternal-infant bonding. The use of evidence-based sepsis calculators has demonstrated reductions in antibiotic use of 50% or more without a concomitant increase in the incidence of early onset sepsis. I have to say that the use of the word bonding, where it says higher levels of care and thus decreased maternal infant bonding, should be changed to say decreased maternal infant establishment of breastfeeding, which is of critical importance to the health of mother and child.
Yeah,
Like,
I totally.
I think the word bonding is used so commonly in reference to the separation of mom and baby, where really it's missing the point of this is, and I was hoping you could help me. Actually, I was thinking about talking to you about this, and I was like, there's got to be another analogy of something else that happens in medical care where, we're doing something that is interfering with the establishment of a normal process, that we could use as an example, to people. Like, I don't know, the one that I thought of first was if you don't introduce sort of solids and increased textures to babies and finger foods sort of in that 9-month period, by the time they get to a certain age, they have feeding difficulty because they miss the developmental stage where they're able to do that and curious, and they become averse and gaggy. But I'm sure there are other examples that we could come up with.
Yeah, let me think about
Put
it.
you on the spot here. You can think about it. I'm
Yeah.
gonna keep going. There was something else about this that I wanted to bring up. So I thought those were both really interesting, and they highlight sort of how some of the things that we do just to be safe can actually cause harm. And then they went on to talk about how this list was created, and they said, a diverse committee with representatives from the Society of Hospital Medicine's Pediatrics Special Interest Group, the American Academy of Pediatrics section on hospital medicine, and the Academic Pediatric Association's Hospital Medicine Special Interest Group solicited a list of recommendations from specified criteria from colleagues in the various society listservs. An iterative process. Recommendations were formatted, merged, and presented with an evidence review of publications of the past 10 years. From over 100 initial recommendations and through 2 rounds of a modified Delphi process, the highest scoring recommendations were chosen to represent the Pediatric Hospital Medicine Choosing Wisely list. This was endorsed by the boards of the Society of Hospital Medicine and the Academic Pediatric Association and peer-reviewed by various AAP specialty groups. So I was thinking about this, and that this, is available in all sorts of specialties, and that it's really looking at unnecessary tests, treatments, and procedures. And that I thought, we should start the process to create a list for breastfeeding medicine. And the first thing that came to mind was pump and dump. Like, to me, that is an unnecessary procedure that women are put through very frequently. I also think that the treatment of a nipple shield falls into this category, and possibly also feeding formula to decrease bilirubin. So those are the first ones that came to my mind. I'm going to start working on my plan.
Yes, I think that would be awesome. And I think that, we could have our own Choosing Wisely campaign just among, in breastfeeding. And the other thing I would say is, rigorous evaluation before a frenotomy. Like, let's use evidence for
Yeah, and make sure that there aren't other treatments that are effective before we just go, oh, I see something and I have scissors right here.
Exactly. That's exactly right. Yeah. Yeah. No, I mean, I think that we could probably contact the Choosing Wisely campaign and just say, hey, how about just like, not using, just the risk of giving a cow's milk based formula to a baby who's going to be exclusively breastfeeding. Look at the very compelling evidence that these babies can have a cow's milk allergy later just by giving them a couple of bottles of cow's milk based formula in the first couple of days. So there's a lot of things that
I would be happy just to start with pump and dump. I think that is like such a common, and it crosses so many specialties. So it's a great place for us because people are aware of Choosing Wisely. And I feel like it would be an opportunity to sort of highlight that this is a mistake that a lot of physicians are making just because of ignorance. It's not taught. You take a whole year of pharmacology and you learn how to do renal dosing, but you don't necessarily learn a ton about how to evaluate for medications when mom's breastfeeding.
Yeah, and I think you're right. I mean, I think pump and dump is a really good one to choose, and the reason why is because the Choosing Wisely campaign is getting rid of all these like, oh, we should do it because we want to be safer. We're covering our rear ends, and that's what the pump and dump recommendation is too, right? It's like, let's just be careful. But then you're doing so much more harm with that recommendation. So I love it. I think that's great. Let's do it. Let's get on it. We have our Stop the Pump and Dump app that we've been trying to launch for the last year. We have it written up about, the things that we should be like not worrying about. We're hoping to get that launched soon. And so we could show them our app too and say, here you go, use it.
Use it.
Use it. Yes, and don't dump it. Yeah, great. Okay, well, I think that we should probably wrap it up.
I think that was a good one. It was fun hanging out.
Really great talking to you. And I can't wait to hear more about the Choosing Wisely. So
I'll keep you in the loop.
Thanks. Okay.
Bye, Anne.
For questions regarding this podcast, please contact us through our website at lacted, lacted.org. We have other educational projects, including the Clinical Question of the Week, our Little Green Book of Breastfeeding Management for Physicians, and our various educational courses and conferences for physicians and other breastfeeding supporters. If you want to see what we look like, check out our Breastfeeding Medicine podcast Facebook page, where you can post any questions or comments about our podcasts. Thanks for listening, and we'll be back with you in about 4 weeks.